Any final specifics before we get ready to jump in? I think we're good to go. I do want to remind everybody, and I'll have Amy just give a little bit of information. This is, Amy, the fourth in the series of 5 of the sessions, and then our final session will be featuring our friends and colleagues who've done a lot of fantastic work around stool-based testing and great follow-up and reducing the no-shows around colonoscopy and doing some fantastic discussion around interventions related to that work. I think actually Amanda might be on the call today, so thanks for joining in. Amy, anything else to say, share about our final session as we get ready to move forward?
Yeah, like Andy said, we'll be talking a lot about that follow-up when we have a positive test. So just a reminder, next week we actually are having it on Thursday instead of Friday like we have been. So next week's will be Thursday at 11.
All right, awesome, very good. And I know that Allie Bain is on the line today too, so I might actually punt to Allie to talk a little bit about some of the local resources in Colorado. Dr. Dorado Brooks from the National Prevention Office at American Cancer Society is one of the chief prevention and control officers, was checking with us, or actually presenting to us on our initial launch of the series about interventions related to stool-based testing and best practices as it relates to the science and the kits and tests themselves. But Allie, can you hear me okay? And are you good being put on the spot today to share a little bit about the work within our ACS local region?
Yeah, sure. I can just do it at the end after you talk about everything you want to talk about. Does that work?
Absolutely. That sounds
Perfect.
great. Okay, perfect. So thanks so much, everybody, for joining. As a quick reminder, we did have Dr. Brooks, of course, presenting. We did have the, with the American Cancer Society around the evidence-based type of interventions and the quality and medical indicators for screening, as well as the science. So that was fantastic. Sharon Worrell and team from Fight CRC about the patient perspective, hearing from the QI initiative and from our state-based director of our work at our health department around interventions, QI work, and thinking about best practices for implementation. We're going to talk a little bit further about some of the evidence-based interventions, and also a bit further about the tracking and really the role of navigation in this, and have Amanda then round us out in the final series talking a little bit about the additional fantastic work that's been done with some of our national partners. And again, Allie sharing some of the local resources in the Colorado and expanding region about resources. So excited, and I think there might be a little bit of duplication or basically a reinforcement of the ideas from Meg, but I'm going to go ahead and share this today. So we will go ahead and get started. Everybody, on behalf of the Colorado Cancer Screening Program, I'm Andy Dwyer. I'm the director of the CCSP program, and I always joke that part of the reason that I'm now directing the program is because everyone I worked with who helped start the program has retired. So by default, I ended up being the director. So I'd like to just say that the work that I'm sharing is based on about 10 years of the work that we've been working on in Colorado. But it really does talk about the expertise based on many of the grantees and folks we worked with for the past decade. So I just want to remind everybody that in terms of looking at evidence-based guidelines and practices, the community guide and our friends at the Centers for Disease Control do have some fantastic advice about what are specific evidence-based interventions, what does evidence mean in terms of implementation, and specific around the FIT and FOBT, as well as now the stool DNA and stool DNA approaches. There's some great work in terms of understanding about what are the most effective methods in terms of implementing work and what should be done to really promote FIT and FOBT work, as well as the stool DNA and stool-based testing type of approaches. So just as a big shout out, based on the evidence from CDC, the things that we know that are most connected to this work relate to small client media, thinking about structural barriers, and then client reminders. And so when we think a little bit about the patients really being connected to an interval of screening over 3 to 5 years at a minimum on an annual basis, interventions for reducing those barriers for returning the test, Administrative barriers such as population management, which we'll talk about, is noted as an evidence-based strategy in the area of cancer prevention and where these tests are implemented. Assistance with appointment scheduling, particularly as a follow-up, setting up alternative screening sites in the follow-up, screening hours, transportation, and the like. And so what I'd like to say is that I think that, of course, that we've seen client reminders, media, and the structural barriers around colorectal cancer screening. In general, this has been recommended, but this can really relate to what we're talking about for implementation of the non-invasive tests like the FIT and FOBT, stool DNA work, as well as thinking about the implications of making that bridge and referral for colonoscopy if needed. So again, I just want to remind everyone that the community guide is where most of our great practices and evidence and where we help guide the interventions we're putting into play and into place. And just a reminder that if we're thinking about this work, we need to really go back to the evidence, and there is sufficient evidence to say in colorectal cancer, these are the things that we should be considering. So thinking further also then about the navigation component, and there's the population management side, which we'll talk, but we're also talking about navigating to get those tests in. A lot of times in terms of the evidence right now, when you think about the patient process from linking to health systems, health screening, diagnostic, treatment, and managing, that we know that there's sufficient evidence right now, particularly as it relates to the navigation work for providing health information, screening tests, linkages to health system, publicly funded health insurance, financial and transportation, that barrier reduction, as well as the conducting screening tests and linked to screening. The evidence is now starting to gain that navigation makes impact in terms of the treatment management, end of life work, but throughout the continuum, navigation is noted as an evidence-based intervention, and now within the CDC guidelines, also an evidence-based practice. But again, that barrier reduction and then ultimately the engagement of patients for reminders and the like is something that we can consider, and particularly as it relates to FIT and FOBT testing and management. Again, the reminder, making sure patients have a means to return the testing kits and ensuring that there is a process in place is amongst those. So a huge shout out to our friends at CDC who are giving great advice, and just a reminder that we should make sure to always think about our interventions that we're putting into play. And that's what we've done, particularly here at the university and with our partners. So when we were the Colorado Colorectal Screening Program specifically, and now that we've evolved to the Colorado Cancer Screening Program, we have learned a lot of our work based on our implementation of flu and FOBT issues in implementation. And when we've started this work, we've always made sure to engage around the evidence base related to the program and implementation of best practices. And one I'd like to highlight is particularly around the flu FIT and the flu and FOBT opportunities. And I know Dr. Michael Potter out of San Francisco, as well as others, have implemented this type of practice, but ultimately it is noted as one of the types of approaches that, paired with an annual based type of opportunity such as flu testing, that a flu and a FIT and FOBT program can be very instrumental in terms of uptake. So ultimately, what we've always been able to do is go back to that community guide, look at what are the best approaches, as well as the RTIPS, the Research Tested Innovation Program, to understand what are best practices and what that guidance is. And in a lot of our work at the university, we've utilized this flu, FIT, and FOBT opportunities to understand who's eligible for screening, thinking about that education, and then setting up the programs within the clinic systems and providing staff training and implementation guides around best practices around FIT and FOBT, as well as our existing data and programs that have been set up to show this really great intervention and follow through in terms of an annual type screening approach. And ultimately, the program partners that we've utilized within the university are our community health centers and our rural health practices. So I think that if you have a chance to explore different types of models, the flu and FIT and FOBT approach has been used, has shown great evidence for making impact. And again, thinking about that adherence for an annual type of approach. So we've always talked ultimately that there's no data that suggests that just doing the FIT and FOBT test one time makes any real reduction in mortality. So it has to be really thought about, and doing a program such as this on an annual type basis, and what are those strategies for us to consider. So again, just as a reminder, if we are thinking about the EBIs and our evidence-based interventions, really thinking through what are those opportunities for reminders and the like. So if we look at client reminders and the like, some of the strategies that have been noted, of course, are thinking about written letters, telephone messages, advising people that they're due for the screening, those client reminders, follow-up printed or telephone reminders, text or discussion with information about indications for benefits and ways to overcome barriers, and assistance in scheduling appointments, particularly if that follow-up fit and FOBT is or that positive and it requires a follow-up. So ultimately, again, a reminder that these reminder systems and all of the opportunities for follow-up and follow-through should be really considered in terms of thinking about a program that's going to last for not just 1 year, but for several years. And there's some really fantastic examples of what other states, other communities, clinic systems have been able to utilize in terms of thinking about how to really implement something of this nature. So on the CDC guide, and then that link that I provided, you can find information about the fact sheets, about phone scripts, about ultimately automated telephone call systems and how to implement something of that nature. But I think the biggest thing that we really just want to talk about is that if you're going to embrace a FIT and FOBT or stool DNA type testing approach, you really have to think about the big picture. It can't just be about a one-shot wonder. It can't just be a mailing for a one-time, one and done with no follow-up or follow-through. It really has to be about thinking about a process. And that would mean also engaging the front desk and your clinical and administration team, your community health worker systems, as well as your navigators, to really think about how you're going to do this and what are the strategies that you're going to deploy to make sure patients and then their family members are clear about what needs to happen in terms of this implementation of distributing FIT and FOBT test, and then ultimately from a year to year to make that work. And if a positive test is found, what needs to be done. So I can't stress enough, use the tools and resources that have already been developed by others. The CDC's done a fantastic job of outlining the evidence base, as well as some great opportunities to understand what are some examples of what worked and what hasn't worked. So this is some of the things that we've worked on in terms of ultimately doing some of that reminder, the awareness. Flu is preventable, but also colon cancer is preventable, colorectal cancer, and taking that opportunity for synergy around shared strategy for prevention. I mean, why not take care of yourself in terms of doing the flu shot and getting that FIT and FOBT test at the same time? It's a great way to have people on site, talk about it, educate it, but ultimately we know that if patients are likely to come in for an annual type visit, pairing this and then having a combined message together has shown great uptake. And just another example of getting the word out, and then really thinking about the population you're reaching. I think some of the things that we've heard back from folks is that it's all great that a stool kit was maybe put forth, that there were mailing campaigns, but a lot of times not everyone speaks English only. So making sure those instructions have a possibility of reaching the population you're reaching. So I know in Colorado, we've done some work with Exact Sciences to ensure that we have our testing kits that have instructions in French, English, Spanish, and then also in Mandarin to ensure that the folks that we're working with have the right type of orientation and have the right tools to reach the connection and the possibility and the communities that they're really working with. The other thing that I think that we've also noticed is that not everyone, in terms of understanding comprehension and reading level, even making sure to use pictures, to have different types of opportunities for YouTube videos and the other that shows how to actually use the test, or that there's graphics for people who might not read or write well, or that quite honestly just medical jargon really is lost upon them. Thinking about these types of approaches and how you're going to implement is something that really needs to be considered when you're thinking about that population. So nothing like sending out some kits and only to realize you've sent something out in a language that nobody reads, and then wondering why you're not getting the test back. So just a huge note, again, a lot of great resources on the CDC site, the link that I provided on the research tested intervention program, our tips, some great opportunity, and we can send those around too. But just a reminder to really think through, is the approach you're working on evidence-based? Do you have a system in place? How are you reaching your teams? And are you really making sure to couple the right materials and messages with the population you're reaching is of utmost importance. So I'm going to take just a quick moment to also, and I know that I've already primed some discussion around population management and then ultimately the one-on-one navigation approach. But I do think in terms of thinking about stool DNA testing approaches, we do have to think about the opportunity for the health management and ultimately overall population and how we're reaching folks. But of course, population management, I think, is a term that's now quite in vogue, especially in the era of EHRs and EMRs, but it's really the aggregation of data. So grouping of the patient data across multiple health information technologies to use this data for an actionable opportunity around resources, an actionable patient record, or actions where providers can improve clinical and financial outcomes. So I think one of the things that we've definitely heard from our systems is that with I think that some of the software and population health management tools, EHRs, EMRs, as well as flagging charts and the like, this is a way that we could really understand who's eligible. But one of the things we can do is really think of doing a scrub of our charts to understand who's over 50, who's not had a colonoscopy, who needs annual screening, and we're able to think about larger population approaches to reach these folks. So it might not be, a one-on-one, very, very in-depth opportunity to navigate every single person at the start, but maybe again, back to those evidence-based approaches, there are mailing opportunities, reminder systems that people need to be screened for FIT and FOBT, directly mailing FIT and FOBTs and stool DNA to get that sort of response, and really thinking about it in more of a bolus and more of a sort of mass opportunity to get the information out, but then putting those systems in place to identify those folks, but ultimately also to understand how to have those reminder systems, those callbacks, the opportunity to then ultimately think about navigating those folks after they have been, have a FIT or a positive FIT and FOBT or stool DNA. Those are the types of approaches that we're talking about. So really, again, I think for this idea of interventions and implementation, it's really thinking about what do you have at your fingertips right now that can help you understand from your whole population within your clinic system or within a group of people who is screened and who is not screened, and how could you really think about opportunities to deploy information about FIT, FOBT testing, stool DNA testing, either in messages or even as a direct intervention, and even maybe targeting folks who are coming in for that flu FIT opportunity, reminding them that colorectal cancer screening is important. And so when they're arriving or when it's time for that flu FIT, reminding in that messaging that it's not just about those shots for the flu shot, it's really about this greater prevention message. So I think I want to just really ensure that we're thinking about what are those approaches, what are those opportunities. I know that in addition to the FIT and FOBT and flu opportunity, there's annual visits around women's health issues, some dental appointment types of approaches. I think again, the name of the game is just making sure that it's around a set or annual opportunity and how to really engage with people around the key message of prevention and making the most, but utilizing that and making sure that it happens not just a one-time wonder, but it's about a sequence so that we can see that mortality reduction after being implemented for 3 to 5 years, particularly around the stool DNA testing approaches is key. But the other thing I want to mention, and I know that others are going to share this, is ultimately the opportunity for patient navigation and ultimately where that individual one-on-one opportunity makes great impact. And I think that we need to focus on ultimately, and particularly for those flu and FIT, for the stool DNA testing approaches for people who test positive, we ultimately want to ensure that patients have a follow-up colonoscopy because, of course, the whole preventative screening cycle is not done unless we're clear that people who show a positive FIT or FOBT or stool DNA test have that full follow-up colonoscopy. And I know within our program in Colorado, we see sometimes within some of our systems over an 80% no-show in terms of people following up that colonoscopy. Part of that has been because, again, not having that ample opportunity for system-based approaches to follow up with folks. But ultimately, if we don't devote navigation resources for an opportunity for that one-on-one intervention with patients to reduce their barriers and improve that access to care, to have that follow-up colonoscopy, we're in a real miss. So I just want to make the distinction between the two of them, because both of them are great opportunities and essential for good fit and FOBT management. But in terms of ultimately thinking about that in complete preventive cycle, navigation has to be engaged, especially around if blood or abnormal tissue is found, or abnormal, DNA is found through these testing approaches. So again, using your EHRs, there's new market of new types of software that embed and engage with EMR and EHRs. Even if you can't do something that's super technical like that, spreadsheets still work really well. And then doing what you can and to have tracking and a plan with the opportunity that you do have in place. Use what you have. It doesn't have to even always be super sophisticated. It just needs to work within the system so that you can identify who's eligible. And again, having that one-on-one for patient support, and how's that going to really be invoked in terms of what you're doing. So plan, plan, plan. I know Meg Phillips had showed a great schematic based on one of the clinic systems, who's done a fantastic job with their stool DNA testing approach, where looking at workflows and the like. But this is actually something that's put forth by our program when we implemented around the annual flu shot type activity. And as you can see, we're looking at the core components, the targeted clinical groups that we're working with, the program materials that were utilized and the like. But it's really nice, a schematic around the training, advertising, daily operations, tracking, test completion, and the results follow-up. So I think if you're going to implement a program such as this moving ahead, making sure that you really engage the folks throughout the continuum and thinking about who you need to really help make sure that you're successful, this type of thing could be a really good opportunity for you to, as a cross-reference, to consider and really think about within your systems where this might work. So again, I know that you've seen a couple different types of workflows, but this is one that is a little generic, but it can help you really consider what LIFT looks like within your system. And again, things such as flu vaccination authorization record and the FIT tracking log. I think I borrowed this, aka stole this from Mike Potter. But ultimately, even thinking at the patient level, what are the kind of tools and tracking mechanisms you can either build into your smart tools from EHR or EMR for tracking, making sure there is something like this at the individual that can help you keep things moving, because after that stool and FIT and FOBT, our DNA card has been mailed, it's ultimately then tracking more on the individual level about what we know about what came back. Has it been utilized? Has it not been worked through? Do you need to do reminders? And again, if that positive FIT or FOBT is happening, making sure that you're clear about moving ahead for next steps. So this just gives a little bit of an example of some general tracking back in early 2012, 2013, where we were looking at the number of folks that were allocated, number that were given, number returned, positive, completed, rate return, positive return, and then ultimately even tracking our rate of cancer long-term. And so this was ultimately looking even from a programmatic standpoint, when we worked with about 10 different clinic systems, what was the impact based on all of the components that we put into place. So again, without that opportunity to have a comprehensive approach for reminders and the like, we might not have seen anywhere from the 60 to 70% range of people returning systems. But even as a program level, it's important that if you are implementing this as a clinic site or as a program, keeping track so you're clear about these sort of trends is super helpful. So I know that we're going to have Amanda and others sharing about this, but what if there's a positive result? The navigation and the tracking remain. And I think I probably beat this down at the beginning of the presentation, but navigation into colonoscopy, again, a must. And a quick reminder that the CCSP program, as well as many folks, have really outlined the opportunity of navigation into colonoscopy. I think most of you on the phone are doing this really well. But of course, it just has to be implicit in education, has to be a key component to let patients know that having a FIT FOBT that does come back positive, that will mean the bridging into colonoscopy, and that navigation process will then, of course, mean education around the GI procedure. What are those barriers around transportation, the reminder systems around the colonoscopy and prep? What happens if there's a positive result and a polyp or a cancer is found, and the like. And so just a reminder that you can visit the CCSP website that also talks about what are those steps for colonoscopy and integration. But I think everyone on the phone is currently a navigator with our program, or someone who's very connected for these resources. But again, just as a reminder that we really do have to think about that barrier reduction, access to care, even for these folks. And so understanding who is the navigator and who's going to do this one-on-one with patients. If they are found to have a positive stool testing type of opportunity, that's going to be definitely key. And one of the things I just want to say about this is that I think on occasion we'll receive calls from folks at the clinic systems that have said, I have a patient for 2 to 3 times who's shown up with a positive FIT and FOBT. Just a quick reminder that one abnormal FIT FOBT or stool DNA definitely denotes the need for colonoscopy. I think on occasion folks aren't always clear that it doesn't mean just one time nothing's wrong. Or that it doesn't need a follow-up. There's folks who've told me that they've gone to a certain type of health fair or the like, and for 2 to 3 years in a row, they've had a positive stool testing kit and want to know what to do as a result. So I think just being really clear with folks about what is that follow-up, and that based on the type of approach that you're doing, that most now the current tests that even one abnormal screen from those types of stool-based testing approaches will mean that referral for colonoscopy. So just as a surveillance and follow-up, and the key, tracking is key. FIT, it's only ever utilized as an evidence-based strategy if we use the correct type of test. So I think Dr. Brooks, and for those of you who didn't hear his summary from several weeks back, he really talked about what are the thresholds for quality, and currently what tests meet that threshold. Not all FIT FOBT tests particularly are created equal, and there's not always the same level of FDA regulation across what's put out in terms of thresholds. It's stronger than it used to be, but I would just advise you all to make sure that you're looking at the type of test you're utilizing, and going back to Gerardo Brooks and others to say, from the information that they put forward from ACS, the Roundtable, and others, to make sure the type of testing approach you're using is legit. 3 to 5 years annually decreases mortality. There's no data to show that using a FIT and FOBT just one time in a population health type strategy will actually show a decrease in mortality. And so that's why I think that using the care coordination, the population management, and the tracking, and making sure that you have a system set up that's not just going to be in place for 1 year, but really has the opportunity to be in existence for 3 to 5 years, and you're building with that kind of longevity in mind. That has to be key, because that data will not actually help hold that up. That if it's only one and done, you actually aren't going to see that type of opportunity for cancer prevention and reduction of mortality that you would otherwise. Those navigation opportunities should be tailored for those who require the most help to preserve resources. And that we've also identified that those who are positive for stool DNA type of approaches are definitely amongst those who should be prioritized. And there has to be a follow-up strategy for these folks moving ahead. And that reminders and working with that referral into colonoscopy is obviously the very much the next step. So again, working with that population management, the tracking, how are you doing at the clinic level? What are you doing with those individual folks? If you're running this from a multi-site program where you're managing several different systems, how are you looking overall? Are you seeing the type of trends? But you ultimately still have to make sure that on that one-on-one level, that there's a test that comes back. There has to be a strategy to really connect with that person about getting into that colonoscopy, and what are those essential approaches. And I know Amanda and others who will be presenting next week on Thursday will have some great advice and some further opportunity to share some great information. So with that, I'm going to stop. We're about half of the hour in, as soon as I can figure out how to stop sharing my screen right now. So let me go ahead and just stop there and see if anything has come up in the chat. So I do want to say I see Diana Redwood and a couple other friends who I have not talked to in a while. So thanks so much for being on. Of course, many of our clinic assistants as well. So Amy, do we have anything in the chat right now that is coming up while I try to figure out how to get this off the screen with my new computer?
Nothing has come up yet. So right now we do welcome you to unmute if you have a question, or you are able to go ahead and put something in the chat. But there's nothing yet.
Okay, great. Well, with that then, I know I just want to be respectful of time and all. And Amanda, I don't want to put you completely on the spot because I'm going to punt to Allie since I've, put her on the spot for today. Allie, I'm going to owe you as well. But Amanda, I think as a promo for next time, next Thursday, and you all presenting, is there anything you wanted to share, I think, building off of today and what folks will be talking about on Thursday? And Amanda, you're on mute, and I know that I totally put you on the spot, so if you can't get off mute, no worries. Okay, we'll see if we can. Okay, we had you for a minute, and now you're gone.
Okay, try now, Amanda.
Okay, sorry about that. I think I was trying to unmute myself while you were trying to unmute me too. No, I think this is a really good entree into next week where we will talk mostly about follow-ups to abnormal fit tests and talk a little bit about registries. And I won't go much into patient navigation since you've already done that. But I think it all is intertwined and the conversation is going strong. So thank you for starting me off for next week, Andy.
Yeah, you're welcome. And I would say, Amanda, that we probably might have slightly different audiences. So reiterating some of your great works in finding and navigation, I think would be completely great as well. So holy cow, Allie Bain, even with being put on the spot today, already has a slide deck. Allie, just tell me, did you have this done? I mean, in the last 30 minutes I've been talking. Are you there? I think you might be on mute.
Sorry, I couldn't get off mute. I already had this done. You're just lucky that I'm just prepared.
Yes, so everybody, just as a huge shout out to Allie, we were going to try to couple her with Dr. Brooks, but his presentation went a bit longer. So, well, that's great that you have this in your back pocket because I did put you on the fly a bit today. But Allie, we'll go ahead and punt to you. And Amanda, huge thanks for all of your working with us and that you'll be on the call next week. And again, feel free to share even some perspective about how navigation has been implemented and working in your community. But Allie, I will go ahead and turn it over to you. And I think if anyone has specific questions or thoughts, we'll go ahead and put those in the chat. And then Amy, the one other thing is I think over the last couple of days, we might have received some questions about approaches and mailing around Fit and FOBT. So maybe at the end, we can put that out as a specific question for folks who may have already implemented and have some advice. But Amy, I'll check in with you offline. So Allie, I'll turn it over to you.
Yeah, so thanks, Andy. And I have no problem being put on the spot. So thanks for doing that. So I am Allie Bain with the American Cancer Society, and I'm a health systems manager for state and primary care. So what that means is I work with clinics, specifically FQHCs, safety net clinics or other clinics that are serving underserved populations to help increase screening rates and HPV vaccination. So I'm just going to kind of briefly talk about ways that we can support much of the activities that Andy just went over and some of the work that we're currently doing in Colorado. Let's see here. So one thing that we really emphasize is the importance of provider and total clinic staff education. It's so important for everybody to be on the same page and understand why screening is important, what the guidelines are, what the test options are, understand where we are in Colorado, and then much to complement Andy's presentation as what are the evidence-based ways that we can increase screening, and then what are those best practices? What have people done in other places, and how can we replicate those within your clinics to meet the needs of your patients? So the presentation, like our standard presentation, is pretty similar to the presentation that Dr. Brooks gave in the first week of this series. So if that's something that you're interested in for your clinic or your provider group or any number of people, just let me know and I'm happy to come and share that with everybody. And then very much to complement Andy's presentation is we really want to help you guys with your health system changes. So we recognize that a lot of what we talk about is much more from a public health standpoint than from a clinic standpoint. So we want to provide whatever level of support you need to help implement those interventions. So that can include leading your quality improvement work, helping you guys work through workflows, knowing that every clinic's capacity and resources are so different. Not very often can we take one workflow from one clinic and just completely copy and paste it to another. So we really want to help you guys figure out what will work for you based on what your clinic has. And then policy implementation. So do you have a policy in place related to colorectal screening? Is it something like every person over 50 is offered a fit kit or is talked to about colorectal cancer screening? So we can definitely help in whatever kind of capacity you need to help support that work. And then I'll talk a little more about patient education materials in just a second, but in regards to client reminders and some of the mailings, we do have messaging for specific populations. So whether that's Hispanic or uninsured, whatever kind of populations you are working with that you need to increase their screening rates, we have developed along with the roundtable some specific messages that you guys can utilize. And so we can talk through those, work through those, and develop some materials to meet the needs of your patients together. And then the other thing related to health systems change is we do occasionally have some grant opportunities to provide direct screening for uninsured patients. So if that is a big need in your community or in your clinic, let us know and we can kind of watch out for those opportunities and try and connect you to additional resources. So in regards to patient education materials, we have a ton of different materials. So the kind of these are two different materials that are on the screen right now. So the one on the left are the conversation cards that go over all of the test types, what to expect, kind of the benefits and the drawbacks, I guess, of every test. And then these are written for patients. So it's a great way, you know, if you have a process in place and when someone checks in and they're due for a colorectal screening, maybe the receptionist or your front desk staff provide them with these materials so they can look through them and be prepared to talk to the doctor about what test they feel like is best for them. And then the materials on the right is what we call our decision aids. So as we know, the tests for colorectal cancer screening are very different and people have different concerns about each test. So this kind of walks people through how concerned they are with various things related to the screening test. So does somebody want to do the prep? Does somebody want to collect their stool sample? And so we can use this information to decide what the best test is for a patient. And then it does include some common myths. You know, everything is really expensive. Nobody in my family has had colorectal cancer, so I don't need to worry about it. And so we help to address some of those things too. So these are available for any clinic. So just let me know if you guys are interested in these and we can definitely get those shared. And then the final thing that we're really trying to do is, because ACS is a neutral third party in most circumstances is we really want to convene community partners around universal challenges. So knowing that in a particular community, it's hard to find follow-up colonoscopies for positive fits for uninsured, or finding transportation for people to get to and from colonoscopies. We know that those are big challenges. So we really want to bring partners together to talk about these issues and figure out how we can work together. And then knowing that we do have competing health systems in certain areas, we want to help people understand that, you know, we all have the same goals. We all want to take care of our patients. And then also we have the opportunity to, again, kind of share those best practices and successes with bringing community partners together, increasing collaboration, and increasing colorectal cancer screening. So that was super fast, but I'm happy to take any questions that anybody has too. And then here is my contact information. So feel free to contact me if you have questions, if you're interested in our resources or our provider education, or if you have a project that you're working on that you need help with.
Thank you so much, Allie. We appreciate you. We will leave it open for a moment just in case anybody is typing in a question. Again, you're welcome to unmute if you would like. So we'll go ahead and just leave it open for a moment here.
So Amy, while people are considering, I know as I pointed out that we had a question earlier about, I think it was mailing, was that correct?
Correct. So basically it was just finding the most economical way to set up a system, you know, when we are talking about mailing a fit test as opposed to direct handout within the office. You know, just postage may not be a lot for one individual test, but it adds up quickly. So finding some good economical ways to get those tests out there. Great.
And so Allie, and I guess even anyone else on the phone, if you want to share some perspective about some approaches that have worked, we'll go ahead and open up that line in addition to the questions. Anybody?
Yeah, Andy, this is Amanda. I can speak about some of the cost savings for fit mailings. I know that's a little bit out of the lane that I was supposed to be talking in, but with some of the clinics that we've worked with in some of our research projects, they have tried out different processes. Obviously, handing it to the patient within a clinical visit is the most economic way, because then the clinic isn't on the line for providing that mailing postage. Of course, always negotiating with your labs, or if it's getting processed internally, you know, thinking about bulk mailings to try to reduce costs is always important. But obviously, if we can get the providers to hand them out as part of usual care, that's the ideal way to save those costs. We've also had a clinic that asked patients if they could to return them directly to the clinic, which also saves money in the return postage. And that has been a good way for staff to be able to check the accuracy of the test as well, make sure that they put the date of collection on the test, and that then they can you know, double check with the patient that they understand that if it's an abnormal, there will have to be follow-up. So there have been quite a few different workflows tested, and I think it just depends on your patient population, but always having that, especially in times like now, always having that option where they don't need to come into the clinic has been that safety net, as we call it.
Awesome. Thank you, Amanda. That's great.
We do have some comments coming into the chat. So I'm going to start with Diana. She has posted a couple things, and then we will get to see Jim. So a couple of things from Diana. First, noting that they had some issues with the post office holding completed FIT tests, and if anyone else has experienced that, maybe just commenting on, what you're able to do troubleshooting there. And then if it's better to send a letter ahead of the FIT test and inform the patient if there's any evidence that might increase a return rate.
So Andy, I can kind of speak to both of these. We have definitely heard that there have been some issues with the post offices in various places holding on to completed FIT kits. And I think we just need to do a little bit more investigating, I guess, as to if the post office is allowed to do that. I mean, if it is labeled as a hazardous material, they should be handling it in the same way that they would handle anything else. But we definitely have heard that from multiple places that is happening. But at this point, I don't have a specific answer for it, and I don't know if anybody else does.
Yeah, this is Amanda. We also have had that issue, I think more often with the HemoSure test. The OC micro test, because it's in a sealed vial, hasn't been as much of an issue. And we've had it once or twice with Ensure if a patient puts too much sample. We've really resolved this just in communicating directly with the post office. I think we had some guidance from one of the lab vendors that had some language to use with these are FDA approved to be returned by mail, and the envelopes are safe and the patients put the samples in the pouch. I think really just opening those lines of communication between clinic staff or the communicator from the clinic with the post office is a good way to start, but definitely call on your lab vendor to help you navigate if you're getting pushback from the post office.
Okay, thank you. And Diana, if you have any additional questions or follow-up on that, feel free to let us know.
And it looks like we have a comment about provider training and navigator training. So I think what I would say is that I know the American Cancer Society and our team, Allie, led by Allie, Allie, I'll let you guys speak for that. On behalf of the CCSP program in Colorado, this series is one of the things we're working in cahoots with a number of our partners, being ACS, our Cancer Coalition, and others. I think if there's any interest in an in-service where it's on-site or doing something that pulls in providers in a more concrete and a dedicated time and the like, we could definitely do that. I know ACS, and again, I'll punt to Allie to talk a little bit about that. If there are specific requests for things that we can help with, the coalition, the cancer screening program, and others would be happy to help, particularly if you're one of our grantees. But even within the community, we could probably think about how to conquer and divide. But I would also say that through the course of this series, in terms of what type of tests to utilize, best practices, and the like, we are sharing the recordings. So this series alone, there can be some modules that I think would be helpful. But in terms of really that one-on-one, being in a center, hosting a specific opportunity, we'd be happy to be responsive to something like that. But ultimately, Allie, in terms of what you've also talked about in terms of being a support from ACS, do you want to talk about how you guys are handling the training and support?
Yeah, so we have been doing a lot of in-person trainings with whether it's providers at a clinic or the whole clinic team. And typically we kind of cover the importance of colorectal screening, the test options, the screening guidelines, and then kind of those evidence-based best practices. But we can also very much tailor the training to whatever the needs of the clinic are. So if you do have specific needs or thoughts, we're happy to kind of accommodate those.
Okay, great. And then Jim, I'm going to go ahead and type in my email address so that if you have some specific questions about that training, and I think I think that Amy, did we address? I'm sorry, I was just trying to multitask here. Diana's additional question about sending a letter ahead of time of a fit test if there's evidence to show that that does show impact on return rate. Did we cover that? And Amanda, you might be our girl to really speak to that one.
Yeah, I'm happy to. We do have evidence that that does increase return rates. I think some of the clinics that we've worked with have found it important to identify patients who have a bad address, but also the evidence is that and we've talked to patients and done quite a bit of qualitative work in understanding the impact of these types of communications. Really seeing that letter from their provider with the clinic letterhead that says you're going to be getting a kit in the mail has been important, but it also really helped our clinics clean up their lists. So if they had, 10% of the letters that came back because the patient had moved, then, saving 10% of the mailings was important, and then they would just try to reach the patient by phone. We've also recently found that text messaging and live phone calls also works. So there's a bit of option depending on your clinic system. The most effective is a live phone call, but that's expensive, especially if you have a large population that needs to get the mailing. So sometimes working from the cheapest option first up can be really effective.
Great. And I'd love to reiterate, I think, Allie, Amanda, your point about on a letterhead and from the medical provider. In a couple of the pilots that we've done at the university, we tried just for some general, a reminder, this is coming, or a reminder, it came to you. And we didn't have as much good luck when it was just a general generic postcard or the like. We saw almost a 20% increase when we coupled it with a note from the provider. And then the one thing that we got some really good advice from folks too, especially in the clinic systems, is that if people see something coming to them and it has, it's just in a standard business issue envelope, it can look like a bill. So we made a lot of effort to make sure that the information we were sending about the test as a preemptive or as a post reminder follow-up is that it came in something that looked friendlier, and then ultimately having the note from their provider, their primary care team on the letterhead, and it made all the impact. But we had to also just move away from the standard, postal stamp and just that white normal issue envelope. So I think really specializing those approaches, and I think you pointed to that and pointed to it too, Amanda, it really did make it a warmer experience, and patients really identified and they took it seriously, as opposed to just when we had something that was more of a postcard type of opportunity. And then we had to, of course, if we did the postcard, we had to just be very careful about the HIPAA implications and what messaging looked like. But I completely, again, about a 20-25% boost when we actually tailored it and the message came from their provider. So this is super great. I know we only have about 5 more minutes. And again, I want to say thank you. And I want to it looks like Amanda might have been opening up her line again to say a few words. Amanda, and I'm super glad that you had joined today, because it will be great for next week. And Allie letting me put you on the spot. So I know we had talked about it a little bit, but Amanda, anything else you wanted to share?
Yeah, thanks, Andy. I was just going to see if I could share one of the introductory letters that we've used. Can you see this on the screen?
Beautiful, yes.
Yeah. So this is a sample of a letter that is in 4 different languages. It's on 2-sided paper, and so it was for this clinic. It was the 4 most common languages that their patient panel spoke, and exactly to what you were saying, this has relatively generic information in it to prevent HIPAA issues. But the dear client, typically they would put in the patient's name. This messaging is based off of what we have heard that patients want to hear. We also did some separate messaging with a Hispanic population in a mainly Spanish-speaking population in LA, so we have some separate Spanish-speaking materials. All of these letters are publicly available to anybody that would like to use them on the mailedfit.org website. And so if we need to put a link in that to my presentation next week, we sure can, so people can use these however they want. There's probably 8 to 10 different types of letters.
That is awesome. Perfect. And I know we referenced a couple different types of opportunities and resources today. I think we'll try to make sure that we have those front and center. And again, this is being recorded, so we'll be able to utilize that. You guys can share this around. So thank you guys a ton. I know Amy has put the evaluation in the chat. I'm really excited because we have some really good conversation today. And Diana, thanks so much for your questions. I hope this was helpful for those of you that are really thinking about putting those logistics into play. And I think Amanda did a beautiful job of setting herself up as a resource and expert for next week on Thursday. Huge thanks. And Allie, again, I think that in the last year or two, our American Cancer Society colleagues have really been knocking it out of the park in the Denver area and the Colorado region. And I want to thank you for all of your great support. And just as a reminder, Allie, I think for anyone joining from out of state, ACS at large throughout the country does provide support in terms of approaches that you've chatted about. Is that correct?
Yeah, absolutely. So I have a counterpart in every state. So if you aren't sure who your ACS person is, I put my email in the chat and you can email me and I can connect you.
All right, excellent. All right, everybody, have a great rest of your afternoon. Everybody, good hand washing measures. Stay safe, healthy, happy. And again, thank you for all of the great work that you do in your systems at the front line. Thanks again so much. Have a great weekend. Amy, are we good?
All set.